questions and answers. Well, welcome. My name is Sherrie Cisneros. I'm the Navigator Program Director, and today we will be discussing co-occurring disorders, mental health, and substance use disorder here at our Navigator Training Focus Series. You will receive the evaluation on our post-event email, so just fill that out and you will be credited for CEUs if you fill out our evaluation. We are a program of Public Health Institute, and we will share the slides and resources when we are done in that post-event email. For the best experience today, we want to make sure there's only one. I should kind of take the rest is for your information, but it's really important to address your questions in the chat to everyone, because then you're going to leave people out and they're not going to know what you're talking about. So your questions are important and we want to share them. So I always start, this is like the repeat that we constantly see, but I just want to remind what CA Bridge is. For those who may be newer to our training sessions, CA Bridge is a nonprofit, and our goal is really basic: 24/7 access to high quality treatment of substance use disorders in California hospital. We hope by 2025, we are right now in 2024, and we have 267 hospitals, woohoo, out of 330. So again, we are very proud of our numbers. What is the CA Bridge model? You guys know this stuff. It's three pillars. The first one's low barrier treatment. That's what our docs do with buprenorphine, or some of our programs have expanded out to naltrexone and other medications. And then what you guys do as navigators: connection to care and community, and a culture of harm reduction. So again, it's a very simple modeled approach, and we are happy that you are part of our program. We have some announcements. And as usual, we're here for you, and we have lots of opportunities for training, for mentoring, coaching. And again, we have our Navigator update on Wednesdays, once a month. Our program manager LaToya runs those informative 30-minute sessions talking about sustainability strategies, documentation tips, work-life balance, CHW update, and professional growth. So always stop by. Those are once a month on Wednesdays. She does send you a calendar invite. And then, of course, we have our Navigator Focus series with an in-depth focus on trending topics. And next month, it'll be substance use disorder in youth. So again, we're always trying to fill the void of education.
Sorry,
Yes,
we can't see your screen.
you can't see my screen? Why not? Hold on, guys. You should have told me. Okay, hold on. Let's go one more time. How about now?
There we go.
All right, so real quickly, I'm going to go back to announcements. Our Navigator update, this is our schedule up until the new year, February, and our Navigator Focus series. Our next month will be substance use disorder in youth, as I was talking about. Thank you, Aiden. And our August Navigator Spotlights, we had 3 this month. And again, if it hasn't came to you, again, we're doing this every month. And so again, there's multiple opportunities. So congratulations to Cecilia, Rosalind, and Jessica. And again, we are doing this every month, so don't be disappointed, and let's congratulate those who are our recipients. We have an update for our Navigator Naloxone Challenge. A lot of you took the challenge, and if you couldn't, you told us why, and we're just happy that you participated. We didn't expect this to be such a huge success, but we congratulate and thank you, navigators. You distributed over 8,500 naloxone kits. Woohoo! Can I get some congratulations for you guys? You did this. That is statewide in August. We had over 41 sites participate, and I'm sure there were more. It's okay if you didn't. Let us know. As long as you were out there promoting overdose awareness. We are very happy. And we will be posting a special acknowledgement for our sites and navigators in the next newsletter. So look for that. That comes out monthly as well. Objectives for today are for our CEUs are verbalize resources for patients with co-occurring conditions in your community, identify strategies for assisting patients who have co-occurring conditions. So real simple, I put the definition by SAMHSA of what is a co-occurring disorder before we get started. We just wanted to define it. What do you guys, do you agree with this? Do you guys see co-occurring disorders? It's basically the coexistence of both of a mental illness and SUD. That is what we're talking about for co-occurring disorders. And our special guest today, I'm very excited to introduce Yvonne Nibo. She has, how many years have I known you, Yvonne? Many, many years. And I can always count on her. She is my go-to person for mental health. She's always so enthusiastic and motivated to come to our trainings. She is an ACSW and a substance use navigator. So again, when I say it makes me feel so proud to present, for her to present to you guys, because she knows where you're coming from. This is directly on what you need to know. So whenever we can tie that together, I'm always so excited because it's, there's a lot of stuff out there, but for your role, we want you to be the best in what you do. So Yvonne, thank you so much for coming and sharing your knowledge and making us all co-occurring disorder experts here with our substance use disorder patients. Yvonne, take it away.
Thank you so much, Sherrie, for that. That's such a nice, kind word. I appreciate that. So before we get started, I just do want to call everyone's attention to, the work that we do and call your attention to where you are, being aware of what's coming up for you, because this is always a very dense topic and always very emotionally triggering subject for some. So if you're able to do that, that's great. If you're not, that's okay. I'll say just stay curious, because curiosity also works as well. So what are co-occurring disorders? Co-occurring, the best way to describe that, I think Sherrie made a good point as to the simple explanation is a combination of substance use disorder and mental illness. So when you have these two together, they call them that they coexisting together, right? That they live together, that they mirror each other sometimes. And then, oftentimes you hear folks use dual diagnosis. That means you're diagnosed with substance use disorder and you also have a mental health, right? And most times you see that individuals navigating mental illness, they're more likely to experience substance use disorder because they do use substances to norm or manage or treat what's coming up for them in mental health. And this is something that has become very prevalent in the US in terms of, do we call it a disease at this point? If we're using a disease model, that co-occurring disorder has become very prevalent in the United States. Next slide. So common occurring challenges that you're going to see is, and I'm sure that you will have seen this in the emergency room, the mental illness that's often associated is anxiety, schizophrenia, bipolar, MDD, major depressive disorder. Conduct disorder I added in here because oftentimes we see youth as well in the ER, right? Or even in urgent care, because only youths below 18 can be diagnosed with conduct disorder. We have PTSD and we have ADHD. Now, ADHD and schizophrenia often also in the ER, we see a lot of that because some of our adult patients, when they come in the ER with ADHD, they don't really understand what's going on. It's either they weren't diagnosed early, but you do see the signs. Schizoaffective could be in here also, but I left that out because schizoaffective disorder sometimes is treated differently with schizophrenia. And then substances that are often misused that you're going to see, and we see in the ER, we see alcohol, we see opioids, and we see stimulant use, which a whole lot of stimulants we see methamphetamine, marijuana, which we see a lot of, hallucinogens, and then prescription drugs, Oxycontin, and all of that. So when you see someone coming to the ER with anxiety, or they have depression, or have bipolar disorder, most times when you run tongue screens, what do you see? You either see ethanol level at 200 and above, or you see fentanyl, or you see methamphetamine, or some people can see benzos, right? If they're taking Adderall for the ADHD, it will show up as well. Next slide. Risk factors. So what we see sometimes with mental illness and substance use is that there are biological factors and genetic vulnerabilities. It's either grandfather had a mental illness that we didn't know about, and we all can agree that 40, 50 years ago, mental illness, it's not being talked about. It's something that is hidden in the family. You don't talk about it at all. We don't want people to know that we're somebody quote unquote crazy. I often hear folks tell me in the ER, oh yeah, I have an uncle Ray who was cray-cray. I'm like, okay, well, Uncle Ray seemed like what you're telling me had some kind of schizophrenia, because Uncle Ray is hearing voices. But what happens is generations move by, and then no one really tells the next generation or acknowledge that I was struggling, this was happening to me. And then the next generation think, oh, something's just wrong, I don't want to talk about it. And then we have the mental health piece itself, right? The numbing, the self-medicated medication due to what is happening. I have anxiety, I have depression, but I don't want to talk about it. I would rather drink alcohol to go to bed at night. I cannot sleep. I don't know what's going on. I don't want to talk about it because, it brings a feeling for me. I take a glass of wine every night just so I can fall asleep and not remember. And then we have the environmental factors. We have the ACE, which is adverse childhood experience. Because not everybody grows up in the best home. Not everybody grows up in the best environment. Not everyone grows up in the best neighborhood, right? So we're going to have experiences that will trigger the mental illness or will trigger the substance use. And then we have trauma. And then trauma, we have sexual assault, sexual abuse, physical, emotional. And then I think this I've come to realize recently that when we talk to patients about trauma, folks often look for the major things, right? Oh, I was sexually assaulted by my grandfather, and that is trauma. But we forget the little trauma. For some people, work trauma, right? If you're 15, 16, and your first job was, you cleaning, and then all of a sudden you had a negative experience, adultism, and then all of a sudden that traumatizes you when it comes to employment. So there are little things, car accidents, right? Or you maybe witness an accident or a death, grief over and over, and all of a sudden here you are, you're having feelings come up for you. So those are also trauma. And I think it's important to acknowledge for our patients that, yeah, that actually what happened to you seems like it is trauma. No, but it's not. I was not abused. No, but that sounds like trauma to me. So the environmental factors actually is also very, very important when we're talking about these issues. Next slide. How do we identify co-occurring disorder? We want to make sure that we are assessing clients when they are patients when they come to the ER. Comprehensive assessment works for me because we want to make sure we're covering all bases, that we're checking every single item, we're asking all the right questions, we're making room for patients to actually, let us know that, oh, I forgot that item. Oh, no, I forgot. Oh, this happened. We want to make sure we're creating a brief space for our patients, right? So we can be able to gather information that we need. And then when patients come in for mental illness, right, we want to make sure that we're screening for substance abuse. We know that is there. Someone comes in for anxiety. Oh, well, man, I can't sleep. I find myself, my heart is racing and shaking. Well, my go-to question is, tell me how you cope. How do you deal with that? I don't know. I go for work. I like to walk. I like to hang out with family. Is there anything else that helps you cope? Right? Occasionally I drink alcohol. Okay, then let's start getting into that. If you can sleep 5 days a week, do you have days that you've gone to bed without drinking? What did that look like? How do you feel about that? So we want to make sure that people come in for depression, any kind of mental illness, that we're screaming for substance abuse. We also want to normalize the conversation. We don't want to skip it, right? For some, it's a touchy subject, but it is okay to assess to see, hey, if you're coping with alcohol and you have anxiety, we want to start educating. Anxiety and alcohol withdrawal will look alike. Is it anxiety or is it the withdrawal symptoms? Then how do we support you in that? Now, individuals presented with co-occurring disorders, they often will exhibit symptoms that are very persistent, they're very severe, or resistant to treatment, right? And then we're going to hear later, and I'm sure all of you have had this experience of, patients that come into the ER and they can't wait, they're out of here. I know, I want to go, I want to sign me out, I'm out of here. And then it becomes a challenge, right? And it's okay to acknowledge that this is a very tough situation. This is a tough diagnosis. This is a tough thing that you're dealing with. That is okay to feel this way, right? But when you're ready, we are here to support you. And then we're going to see long phase of abstinence needed prior to diagnosis. And this one happens mostly for folks with alcohol use or stimulants use. We're going to see that, where you have someone go for a very long time, they don't drink or they don't use, and all of a sudden something happens, they go all the way down. Or you're going to see, and this also happens in mental health community clinics, where someone can be diagnosed with depression, but if you look, they've been using stimulant for like a year, they've been drinking for 2 years, then how do you now give someone a diagnosis of MDD or anxiety or bipolar when those symptoms could mirror also the diagnosis itself? So we want to make sure that someone has come off of alcohol or substances for a very long time before we can begin to diagnose them, because the withdrawals, signs and symptoms look the same. Next slide. Substance-induced concerns. This is targeted to what I just talked about in terms of withdrawal symptoms looking like. What does it look like? If patients have gone down binge using for 5 days straight, 6 days straight, and we've seen this, it triggers psychosis, and those are called substance-induced psychosis, right? And we're going to see SI. I want to hurt myself. What does that really look like? You've been using for 6 days straight, right? Are you really thinking of hurting yourself, or is just the substances? So psychosis we include, and I'm sure you all have seen this in the ER or in inpatient, delusions happen. Hallucination is a big one. I feel like I'm hearing voices, I'm seeing things, and things are moving. I'm seeing lights, it's flashing, I'm seeing little balls, around. This is also very normal when people are withdrawing or when people have been used for a very long time. So substances can induce psychosis. And we know that it is important to, when patients come in and they've been binge using, that we educate them and that our staff as to what is going on. Bipolar disorder, this is also we see a lot in schizophrenia. The signs of it will include manic episode or hypomanic episode. Manic episodes or hypomanic, when someone goes on, they're really extremely happy and they're laughing, they cannot stop laughing. They're hyper aroused, or they go into a very low, I don't want to talk to anybody. They become extremely agitative. You cannot get them to cooperate at all. Or someone becomes really very teary. These are the patients that we see, they're talking to you the next time, and then all of a sudden they cry. And then they become really, really sad, and then they become really happy again. So we're going to see the up and down phase or with these patients, especially with bipolar. And then depressive disorder. This one is also tricky, right? Because there's a certain limit of time before we can actually call it a disorder, because that means something is out of order, and something has to be wrong for a long time for it to be out of order. So depressive symptom will present as a form of depression after you use substances. I have, patients that will come in, they tell you, I use PCP, I stayed up, and I want to use a little bit of fentanyl, and then now they're feeling bad. They turn red, their eyes are red, and then they start crying. And these are patients that you've known maybe from past experiences that is not the typical behavior, right? And then this is also sometimes may not even be related to intoxication or withdrawal, and it's okay to explore that, right? And then we have anxiety. Individuals will experience anxiety or panic attack due to substance use. If you drank a certain amount of alcohol, and this is for me, I find it very helpful to ask patients what kind of alcohol they use, right? And it drives my the staff crazy. Why are we asking this question? Why is it important to know? They're just drinking. Well, I want to know if you're drinking Corona, if you're drinking Modelo, if you're drinking Heineken, the alcohol consistencies are not the same, right? If you drink Heineken and if you drink Modelo, they have different amount of alcohol level. So your anxiety will look different in Modelo than it will look in Heineken, right? And people will begin to feel differently as well. Like I feel a little bit of my hand, my chest is, my hat's tingling a little bit. Okay, when did it start? It started about 3 days ago. What changed? Oh, I had it when I was with friends and I had, a couple of shots. Okay, did you drink just a shot? Did you mix it with anything else? And then you kind of educate them on that to let them know that, this is what is happening. It is withdrawal. Yeah, maybe it's a panic attack. It happened one time. So this is really, really crucial to discuss with patients. And then we see sleep problems. For stimulant use, they stay up for a very long time, right? They cannot sleep. And this is dangerous too, because what happens is when you've used an upper for a very long time, someone hands you fentanyl, right? And we know the possibility of what could happen. You could lose track of the amount that you used to use, and that becomes a problem. So it's also important to educate in terms of sleep. And delirium, we see delirium. This usually happens with our older population, right? Between 40-something, 50. This one is also very tricky because there are so many other medical conditions that could trigger delirium. I actually had a 22-year-old last week with this delirium. She also had seizure, but also had some heart condition, but alcohol level was at 439, right? And it becomes really tricky. Okay, what do we do? What are we addressing first? Then we're going to have neurocognitive disorders, right? This is also very challenging to deal with, but it's also very, very somehow easy to spot. When we see patients that are, their responses are not the norm, we want to explore that. I'm one of those that walk into the ER, someone is sitting and they're just dazing off and their legs crossed and legs are shaking. I want to explore that. Hey, can we check in with this patient, make sure things are well, right? The nurses, you're talking to them and they're like, but they're not really understanding. Is there really something neurologically happening? Do they have the cognitive capacity or the ability to understand what is happening, right? And then we can differentiate that between is it neurological issue or this is something that was triggered by the use. And I've seen this before where someone, a 19-year-old used wax, a combination of wax, added PCP in there and then threw in a little bit of cocaine, and it just became all of a sudden, well, what is really happening? Cannot comprehend what's going on. So it's really important that these are the things that might, some disorders that could be triggered by substances. So we want to differentiate. Is it a substance-induced psychosis? Is it substance-induced depression? Is it substance-induced anxiety, right? Before we begin to diagnose. And sometimes physicians will tell you that, oh no, this patient, I think it looks like bipolar. Well, is it really, right? Because we want to be very, very careful with the diagnosis to make sure, rule everything out before we give the diagnosis, because once that happens, it stays with the patient or the client. Next slide. Barriers to treatment. Co-occurring is very challenging to treat. Luckily, a lot of facilities are now prioritizing co-occurring because oftentimes you cannot treat one without the other. And about 6 years ago, we used to treat just substance use and mental illness treated differently, but you have to be able to treat them together. But we're not where we want to be yet. We still have barriers, right? Inability to bridge the gap of facilities actually hiring and being able to maintain staff to take care of the patients is a problem, right? We know that for us in this field, it's not about the money. We do it because of an experience, right? Or because of life challenges, or because we're just compassionate. But sometimes in an agency, people are overworked, they don't have staff, and it's not such, maybe the organization's value doesn't really align with yours, and we see a bit of a cycle of folks leaving. So inability to bridge the gap of staff and the personal issues continues to be a problem. And then staff that are also educated and then have the knowledge to deal with the situation. And then stigma, this is a big one, but I'm so proud to say that we've talked about stigma over, and we keep doing that over and over. And the importance of stigma cannot be a thing. Right? We need to see substance abuse. It is a medical condition, right? And we need to treat it the same way. If you break a leg, you have a cast, right? So why not put a cast on a soul or whatever we want to call it? So stigma, we're still working on, but I'm so glad to say that it's not what it was 6 years ago, right? Stigma around medication. There's a thing with medication. People, I hear patients will say, I don't want to take medication. I don't want to take medication. But what is it with the medication, right? Sometimes we all need a little bit of help. And I use the car incident for my patients or my clients. If you have a car you're driving, do you take your car to the shop? At least once a year. If you're driving electric, you have to change the battery. If you don't have electric, you have to put what? Oil change once every 6 months, right? So medication is the tune-up. You need to make sure you change your oil and all the liquids in your car so your car can function to take you where you need to go. Same with medication. It does the same to the body. It's a tune-up to give your body the body that serves you what you need it to go. And that often sometimes makes sense for some patients. Sometimes they're like, yeah, I don't know what that means. And the lack of access of treatment, we still know as navigators that this is a challenge. Finding treatment that is low barrier. We are, headed in the right direction, but not quite there yet. We want to make sure this access is very easy. We don't have to go through 20, 30 pages of assessment or intake to get patient into treatment. That continues to be a problem. And then policy, right? In terms of medical, whether you have insurance, PPO, what is your deductible? That continues to be an issue, which ties into a bigger picture of we want to make sure where we're aligned in terms of where we're votes and all that, right? Thanks to medical expansion, there's been a lot of revamp in medical expansion that has really allowed some programs like contingency management in place to treat stimulant use, but we're not quite there yet, but we are headed in the right direction. Next slide. Treatments, right? Yes, we've talked about all of this, the barriers, we've talked about the disease itself, but how do we treat it? Cognitive behavior therapist and DBT, ACT, they've all been found to be helpful in treating co-occurring disorders. But CBT I love because it targets three things: your thought process, your feelings, and your behavior, which is why the mental health piece is important, right? Because if someone is taking medication, if you're giving Suboxone in the ER, you're going to feel different, right? Because this is not the norm. These are agonists, right? The brain begins to feel a bit different. And then what happens is that's what your thoughts are, right? And then the feeling of this, I don't like how it makes me feel, right? It's either I'm overstimulated or not. That is the feeling. And then the behavior, you either stop taking medication or you start acting differently. You start self-isolating, right? So the reason why the mental health piece is important, the therapy is important, is you take the medication and the therapy and the mental health piece kind of help manage the behavior piece of it. So they do go hand in hand, right? And it gives you coping skills as well to manage your feeling. What's coming up for you? Let's sit with that for a little bit. Right? It could be journal, it could be walking. Let's come up with something to help you cope with the feeling. I actually had a patient one time that, was battling at one point with abstinence because relapse prevention is important to me. We came up with a plan. I used to buy my drug by a liquor store. Now, when I get on the bus, I get very overly stimulated because I'm remembering my transaction with my buyer, my dealer, and all of that. Okay, what do we do? Do you have anybody you can call when you pass a liquor store? At one point, I was his coping skill. He will call me, oh, I'm going to get on the bus. I'm going downtown. All right, why don't you call me at this time when you pass the store? That is your coping skill, right? And that's the piece of the functional analysis part of it, the 5 W's, the when, the where, the what, right? And then the who. That's what the 5 W's are. And then coping skill training and the relapse prevention I just talked about. So this is really about how do we get folks to manage their thought process, right? Bring it down to how you feel, sit with it, and then let's adjust the behavior modification. That's why CBT really works. Next slide. Triggers and stressors. We can talk about CBT, feelings, thought, behavior without stress, triggers and stressors. It's important for me to explore triggers. What is the trigger? I relapsed yesterday. What are the stressors? Oh, I don't know. Well, let's not talk about stressors, triggers. What changed 3 days ago? Oh, well, my girlfriend just broke off with me. That is a trigger. That is the stressor. How do we begin to prepare you then for loss next time? And the external triggers will be people. I talked about drug dealers and friends that uses drug, bar, right? Where you used to purchase drug, the drug itself. If you used to shoot, if you see a needle, people drawing blood, it becomes the trigger, like the feeling begins to come back, right? You see media, TV, and TV and adverts about drugs, you get overly stimulated. Time frames, right? We have holidays, we have your families, when they come visit you, payday, you get money. If that's your pattern back in the day, when I get paid, I'm going to buy drugs, it becomes a trigger. Internal stressor is your anxiety, anger. We're going to see frustration, overly excitement, boredom, fatigue, happiness. We want to explore all of this, right? To prepare folks that when this come up, what happens? When you feel anger, what happens after that? When you're bored, do your mind begin to wonder like, I want to go buy drugs. When I feel really tired, when I'm happy, overly stimulated, what happens? So it's important to explore all of that. Relapse prevention is really important. We need to, work with patients when they come with us to prepare them for relapse. I actually had a staff say, well, why are you telling them about relapse prevention? Are you saying that you want them to go back to drinking? No, I think it's very, very safe to practice that. We want to prepare people for the possibility of relapse because we know this is a journey. If you're trying to stay, if your abstinence is what you want, how do I get you to do that? Let's build a future container. In 4 months, right? What will be happening? What will we be doing? Let's map up a schedule. Let's have a calendar. Let's get you prepared to make sure, right, that we are safe. And let's revisit that 4 months because then maybe in 4 months things have changed and then we're gonna adjust from there. So it's really important to practice with our patients when we send them off in the ER. I have a worksheet, anyone interested, I can email to you that I really sit and plan relapse prevention for clients. And then I talk about urge surfing. Let's try that a little bit. Let's see when the urges come up, what happens? What do you usually do when you have urges? And then let's practice that for a little bit. Okay, you go to the store. Then what happens if you don't go to the store and this is happening? What do you do? And patients will actually educate you. They will tell you, but they don't have the word for it. Then it becomes our job to give them the word and have it make sense for them. Mindfulness-based relapse prevention is important because what we're trying to do is to help our clients build a tolerance through acceptance, right? And not to react, not, oh, this happened to me, I want to go use, but this happened to me, how do I sit with it for a minute? Acknowledge that it's painful to feel this because this just happened, but how do I accept this happened to me, and I'm going to find a way to be okay with it without something to numb. Sitting with our feelings is very difficult. But when you've gone through experiences, trauma, sitting with your feelings is so difficult. It's very hard. But we want to make sure that we're creating the tolerance through acceptance versus reactivity with our patients. I will tie this back to Sherrie.
Right, and we put this up because people with mental illness are more likely to experience SUD than those not affected by a mental illness. So always make sure that you're assessing both, that you know what co-occurring and you feel comfortable with talking on both, both the mental health and the SUD. So we just really want you to be aware that this is, kind of common in the SUD world. So definitely just make note of that. Yvonne, I'm going to pass it to you for your last slide.
So we cannot do all this work without caring for ourselves. And when I talk about self-care, is not just about physical care, right? It's not about how you treat yourself. But if that's what works for you, that is totally fine, right? We need to also be doing our own internal work in terms of self-care. Self-care is a personal and professional responsibility. It allows us to continue to help ourselves but also help others. I highly encourage creating a self-care plan. You want to plan ahead before crisis. Someone goes, well, what does it mean things are going to happen? Yeah, we live in a real world. We cannot predict what's going to happen. We don't have control over that, but it is okay to plan ahead. If I'm going to go into work today, Fridays, and I've noticed a pattern in my ER is, well, I usually have 5, 6 patients. I'm going to have 3 overdoses. I'm going to have this. What do? I want to make sure that I prepare myself for the day, right? If I'm not feeling really good, what can I do for myself to make sure that I'm going to go into work, be my whole self? If I'm taking part of myself, it's okay. What part of myself am I taking to work? I want to acknowledge that. We also want to create a personal brave space. Brave space for me has been really important. I've been exploring it the past 8 months. Some people call you safe space, but I think the brave space worked for me because what does bravery really look like? Being able to be vulnerable that I'm not feeling good today. Being able to be vulnerable to say, today is just not feeling right for me. I feel really triggered today. I feel really overwhelmed today. I didn't feel seen today, right? And that's okay. Being vulnerable enough to acknowledge that is the bravery for me. And I tell that to my clients, patients, man, what a thing you just shared. You don't know me, we just met, right? But I really want to thank you for sharing that experience. That is truly important. And I appreciate you for doing that. So I always want to make sure that I do the same for myself, for the staff that I work with, the same for the patients, to create a brave space for people to come in and be able to feel seen and feel heard. Sometimes people feel heard, but they don't feel seen. But being seen is really important because really, if we want to ask for bravery, I want to be able to tell someone, you know what, I see you. And you've showed so much strength today. I do see you. That's what bravery looks like to me. So we want to make sure we're doing the same for ourselves. And safe space is creating a space work for you. That is amazing. But let's start building brave spaces for people as well.
Wow. Thank you, Yvonne. There's so much there that we can use as substance use navigators. And I want to acknowledge that people want your relapse prevention worksheet. So if you give that to us, we can give it out in our post-event email. We can make a PDF and we can forward that to you guys. So definitely thank you for so many tips and strategies and just the knowledge. We thank you, and always plan for yourself. Thanks so much, Yvonne.
Everybody.
And if you have questions, we're going to get to the end. We're going to get through this. And next step is our wonderful program engagement coordinator, Chaia Vang. She's going to talk about suicide awareness and prevention.
Hello, everyone. So today I am actually going to start off by sharing a very short patient story. When I first started off as a navigator, I had a female patient that had follow up with me after seeing her in the ER a week later. First, she sends me a text that she couldn't make it to her appointment due to transportation because she lives on the outskirts of town. And then right after she sends me the text, in like less than 2 minutes, she calls me saying that her boyfriend doesn't want her to do treatment. She's scared. She's just going to go back to drinking if she stays with him. And then we talk a little bit more for a few more minutes, right? And then she starts crying that she wasn't worthy. She's just going to go die, and she's just going to drink until her death. And then she was really quick to hang out like right away. She didn't even like give me time to like interject or anything. She just said, "Oh, you know what? I'm gonna go. I'm gonna find a ride." And then I lost her after that. Couldn't talk to her anymore. Couldn't call her, reach her via phone or anything. She never came back to the ER, and that just made me feel really, really hopeless and just horrible because I didn't know what to do. I didn't know what happened to her at all. So this experience, I don't know if any of you navigators have something similar happen, but it really highlights that this is a critical issue that we as navigators encounter in our daily work. It just enforces the need for us to be prepared and be equipped with proper suicide awareness and prevention strategies to be ready to respond effectively in a crisis situation like this, which I'm just going to go over more with what Yvonne has already shared. So did you know that CDC reported nearly 50,000 people died last year by suicide? Died by suicide last year in the United States. And then what's even more concerning is that more than half of these deaths involve firearm. 5 to 7% are estimated to be intentional overdose. Very simple, something that my patient had mentioned to me. And then in 2021, we also saw a high increase in rate of suicide for adults ages 55 and higher too. So why are we showing you guys these statistics? By understanding the data, we can take more meaningful steps into our roles towards saving lives. How did you react when you heard these statistics? What emotions came up when you think about patients who are at risk, such as having firearms or overdoses or being 55 years or older? How should you interact with these patients? Next slide. And then keep in mind that all these are risk factors. They can go undiagnosed. One of the biggest factor is relationship problem. But if you look also at the diagram, one third have a substance use that contributes to suicide. This study was actually done in 2015, which was pre-COVID. So imagine after COVID, the increase in risk factors and what impact that has on suicide. Social isolation, lack of support, and again, easy access to lethal means. So it's just important to recognize that these factors can interact in complex ways that make it make individuals some individuals more vulnerable to suicide than others. So can you think of anyone that has struggled in silence, especially when I went over these risk factors? Next slide. So suicide disproportionately affects certain population groups, and as navigators in the emergency department, it's important to understand who is at higher risk. So statistically, the following groups are impacted by suicide. Males are more likely to die by suicide than females. American Indian and Alaskan natives and whites tend to have some of the highest group of suicide rates. Older adults, as I mentioned before, especially due to those who are isolated or dealing with chronic illness, are at risk. Veterans are actually alarmingly very high due to PTSD, depression, and challenges of transitioning back into civilian life. Those living in rural areas, often due to isolation, limited access to resources overall, and economic stress. And then LGBTQ youth and adults, they are at very elevated risk due to discrimination, bullying, and having a lack of support. Now, let me ask you all this. Doesn't this sound like the patient population that we are seeing or you're seeing in your emergency room for substance use and mental health conditions already? As navigators, you are often the first point of contact for these vulnerable patients when they seek help in the emergency room. So when working with patients from these high-risk group, your awareness of their increased vulnerability can help you ask more pointed questions and identify potential warning signs of suicide ideation earlier. And then recognize the signs and respond appropriately is the key to suicide prevention. Most suicide people show signs that they're thinking of suicide, either in conversations, through actions, or what's popular these days for communication, social media. That could be on Facebook, Snapchat, Twitter, TikTok, Do you know any warning signs? Put it in the chat for me. Ooh. Trying to see the chat. There are verbal cues and nonverbal cues. And for the purpose of time, we will go skip over that real quick. But just think of that. And a way to do it is to also ask directly to the patient when appropriate is, are you thinking of harming yourself or are you thinking of suicide? And the following are just tips for you to review, but for you, the most important For most of you in the hospital or an emergency room setting, you should follow your site's protocol for suicide. Next slide. And then as a navigator in the emergency department, often you will be the first point of contact, like I said, when patients are in distress. It's crucial to be familiar and updated with your site-specific protocols related to suicide prevention and patient safety. So what are some specific steps to follow when a patient presents with suicide ideation or attempts? And then what happens when a patient expresses harm to themselves? What are the immediate actions? Understanding your role and expectations at your site can really help set the tone for a supportive care plan. And then these are some of the best practices for co-occurring disorders. And I believe that all of our navigators do this best because your role involves creating a safe and non-judgmental space for patients to open up about their challenges. Know when to take immediate action and consult with your health team. That way you can all work together to develop a plan for your patient and connect them to the right resources, whether that's immediate psychiatric care, social services, or mental health counseling. And then always, as mentioned before, practice self-care. Debrief with your peers after a potential crisis. After being in a situation, you can become emotionally drained. So build on your own peer support, on your own support system. And with that, I'm going to put a plug. Come to our Navigator peer support group. Our next one is next Wednesday, September 25th. And that will be in our post-event email too. So remember, you do not have to be an expert in helping your patients, but you are a key player in identifying and intervening those who are at high risk. Recognizing that we may already be serving this patient population, we can better support patients in their darkest moments and potentially save their lives. So just let me know in the chat, is there anything else you have incorporated into your role as a navigator? See if anything comes through, but we can go on to the next slide too. And then these are just some resources. Of course, 988, the 24/7 line that you can call or text. A lot of navigators have been asking recently for support for family members or those who have survived. So there's Friends for Survival, and then there's also a directory of support for survivors. And then in case you didn't notice, a lot of this information is from the suicideispreventable.org website. So make sure you check that out. And I am going to hand it over to LaToya.
All right, thank you, Chaia. Very, very helpful and really great content. So I'm going to be reviewing some stuff about legal requirements. So next slide. As we've heard, when assisting patients in accessing care, some complex health situations may come up, especially when you're dealing with substance use and mental health issues that are co-occurring. While you always want to adhere to your organization's specific training, you also want to be in the practice of thinking about supporting the patient. So that's what we're going to be talking about. When the patient is wanting to leave AMA, the best thing that you can do is figure out how you can support them. So using those great motivational interviewing skills of, active listening and asking open-ended questions, you can try to understand why the patient is wanting to leave before they're medically cleared. And then this can also be an opportunity to provide, information that may put their mind at ease, or at the very least, plant the seed of what follow-up care might look like. So consider bringing in a nurse, the provider, social worker, to pretty much whoever is part of the healthcare team, to communicate the treatment plan. That might be something that puts their mind at ease, them understanding, what's going to take place during their visit. Maybe they're concerned about going into withdrawals while they're there. And so communicating what treatment is available while they're at the hospital can help their decision to stay. Maybe they're concerned about how they're going to be treated. So letting them know that you'll be there to support them because they're establishing that rapport with you. They're understanding that, you're not going to use stigmatizing language, and you're going to be more compassionate and understanding with them, even if they fear that the rest of the healthcare team is not. And so that helps you, again, to just build that rapport and put their mind at ease. And then let them know that you'll connect them to ongoing care as well. But no matter what, always respect the patient's right to make decisions for themselves. So if the patient ultimately decides to leave AMA, we do have to respect that. So what can you do in that situation, right? Arm them with a safety plan. That's what you can do. So you can say something like, you have every right to leave. And I want you to be safe. Can you please take this information with you in case you need it? Or in case things change. So when we're talking about a safety plan, it can look like, letting the patient know where they can access the resources that they need, if it's substance use and mental health resources, if it's, shelter, whatever those resources are, let them know, here's the resources you can access, but tell them verbally and give it to them in writing in case they're not in the mindset that they can remember what you're telling them. And then always make sure that the resources you provide include crisis hotlines like the ones that Chaia mentioned just before. Ask if they want an appointment for follow-up care at another facility. So maybe they don't want to stay and get treated there, but they're willing to stick around while you schedule an appointment for them. Make that offer before they leave. See what they will allow you to help them with. And then any small act of kindness, like offering them a bite to eat, something to drink before they go, or transportation to wherever they're headed to make sure that they get there safely, those will have a lasting effect with that patient. And again, still planting that seed and then watering it, so that it hopefully blooms into something more fruitful for the patient. Make sure that the patient understands that they can always come back. That's super important, that no matter what, even if they're leaving AMA, we're not passing judgment, we're not mad at them, we just want to help them, so you can always come back. And then lastly, ask if you can follow up with them. Well, but ask in a way that's like, hey, is it okay that I check in with you later? Or I'd like to check in with you later and make sure you made it to such and such place. So just see how you are. What's the best way that I can contact you? Ask if you can follow up the next day or in a couple of days. Maybe that feels more acceptable to them. And then actually follow up. So that's another super important part of that is offer to follow up, get a way to contact them, and then actually follow up and see if there's anything else down the road that that they need. So support, communication, and resources are some really impactful things that you can implement to when navigating patients, especially with co-occurring disorders. So consider, as I move on to the next slide, what else you could incorporate into your navigator role. And so, can a patient have mental health issue and not be in crisis? Of course. And so when it comes to legal holds, we are typically talking about crisis situations. And so just a bit ago, I mentioned that patients have a right to leave, and they absolutely do. There are some exceptions to that, though. And so those exceptions are in the form of legal holds. And I'll try to tie this up really quickly because we're getting close on time. But primarily right now, I'm going to focus on the 5150 and the 1799 holds in the state of California. There are additional holds, but right now those are some of our most common ones. The 1799 hold is typically done by emergency physicians, and they are meant to detain the patient up to 24 hours so that, you know, they can be evaluated and see if a further hold is needed or whatever help that they might need. A 5150 is typically when the patient is deemed to be a danger to themselves, others, or they're really unable to care for themselves due to the mental illness. And just like Yvonne mentioned earlier, there could be some kind of you know, mixture of like the withdrawal symptoms or the intoxication of substance use that is presenting like mental illness. It could be both things occurring and presenting certain ways. So really work closely with the social worker and the rest of your healthcare team to help you understand what the processes are of these holds within your organization or your hospital. And then what takes place after the hold. So yes, holds occur. Find out what your hospital's policy is and what that workflow looks like for when a hold is lifted. What typically when a hold is lifted, you'll be able to step into, you know, advocating for patient care, making recommendations, but ultimately know and understand that the provider, it's up to the provider to decide the course of action. So that's why it's really important to, you know, connect with your healthcare team and discuss those next courses of action. And then for the safety of you and the patient, always stay within your scope and consult with the healthcare team before talking with the patient. We've done a training in the past about restraints. So sometimes patients are not restrained and they're under the influence, and sometimes, you know, things can happen. So always check in with the provider and or the nurse before you go in to speak with patient. Make sure everything's cool. Make sure that it's all right that you go in there. And then so again, once the hold is lifted, you can ease into your motivational interviewing skills, and then proceed with kind of some of the usual skills that you have of like referrals to outpatient, mental health services, making sure at least that they have their appointments, and then whatever else is decided on in collaboration with the healthcare team. I'm going to reiterate again the importance of knowing what your role is in all of this when it comes to legal holds and when it comes to patients with co-occurring disorders wanting to leave AMA, and always stay within your scope. Okay. And so I had to do it really quickly, but I did it, and that's it for my part. Next slide.
So we do have a question in the chat. If a physician initiates 5150 or 1799, what is the next step to make it legal? Well, it depends at your hospital. That's why we say go to your hospital, because sometimes there is somebody in your emergency room or in your hospital that can write the legal hold. Sometimes it's calling a PET team from the county to come and make that assessment to put the hold. So it really depends on your facility, but there has to be somebody who can legally write the hold. So that's the next step. So if you don't know at your facility, like you said, different hospitals have a different process. So really follow that up. We are at the last minute. We do not have time for questions. If you want to put the question in the chat, we right after this session are having our Q&A time. If you go on the Slack channel and Chaia can put it in the chat, we can follow up with your question at our Q&A time at 12 to 12:30. So Chaia, if you could put that in the chat. There are a few other things, and if you want to stick around and ask a question, that's fine too. But I did want to present our partnership with Cypress Resilience Project. Is offering our mental health first aid certification for our CA Bridge Navigators. It's completely free. It's an 8-hour course. And for you guys, it's free. Otherwise, they charge hospitals, they charge people to take this course. But with you, for our navigators, we are guaranteed one training course for 30 spots. So please register, you guys. It's very, very important that you register for this mental health first aid certification brought to you by Cypress Resilience Project. If you use the QR code, you can sign up, and it is a phenomenal training. I took it. Most of us have taken it, and you do get certified, and most hospitals will accept that certification. It is an 8-hour course. There's an hour lunch break, but it really does go by very quickly. It's not what you think. So if you're interested in that, please check out the QR code. These are some takeaways. We'll have you read them. And what I just really want to highlight is understand, we can't say that enough, understand your organization's policies and your role. And if you're not clear, go to your supervisor, your social worker for the department, and just ask them, hey, I just had a training with CA Bridge. I want to know our processes. You know, what is it? How do we take care of a patient that's on a hold? Please ask, because each hospital is different. So again, and always just provide your stigma-free, non-judgmental environment, right? That goes for our substance use and our mental health patients. As always, we have resources on our website. We have our CA Bridge Academy for more trainings. And again, if you guys need anything, please, mentors@cabridge.org. We are always here to support you. And if you have a question, you can stay here for a minute. We're going to jump over to our Q&A time. Thank you to our speakers today. Outstanding job. I hope you guys have a clearer view of your role at when it comes to co-occurring disorders. So again, this is just a small piece, but I think it's really geared to you guys. Thank you very much, and we will see you. Bye.